Hello, everyone. This is the inaugural episode of the Redefined Health Education podcast. I'm your host, Dr. Katie Obright. Let's do this. I started Redefined Health Education in 2020, just like a lot of other people started a lot of other things during 2020 because of the pandemic. I started a cash-based practice in January of 2020 in Pittsburgh. Great timing. As you could imagine, my very successful and profitable cash-based practice in the first 3 months was awesome until the world shut down. And then I had to figure out another way to feed my family because I was the sole provider of my 2 little boys, Hunter and Jimmy. My husband was in grad school at the time. So I needed to find another way to do things. So I started putting some continuing education courses together. I worked with a couple of local Pilates and yoga teacher training programs and came up with their helped them develop their anatomy curriculum. And then from there, my interest in education just kind of grew. And then I had other friends and colleagues that were interested in putting their continuing education out there for everyone to enjoy and to experience. And so Redefined Health Education was born, and now it is a platform, and it's a continuing education company that specializes in live virtual continuing education courses for healthcare providers and fitness professionals. And it has really blossomed. I have been so humbled and so pleasantly surprised at where this has gone. So this is the inaugural episode of this podcast, and I am so excited to bring it to you. It was actually recorded in the summer of 2020, and right now we are currently in May of 2021. So I finally am getting this out there to people, but this episode is really special and it's really near and dear to my heart. I'm interviewing and talking to my friend, Dr. Rachel Neuhold, who I met when we both worked together at the University of Oklahoma's Cancer Center. We talk about a lot of awesome topics, and it really goes into detail about how working in a cancer setting as an orthopedic specialist really changed me and really upped the ante for me. So I would definitely recommend listening the whole way through. There's definitely some laughs, but also some almost cries. So listen to both parts. Part 1 is it's a little more than 30 minutes, and then part 2 is a little less than 30 minutes. So we'll try to keep episodes to around 20 to 30 minutes, and you'll get to experience all of my awesome colleagues and partners that I work with in this company. You'll meet a lot of the educators that are putting courses out there so you can get their background and their stories. If you haven't already, we are on all of the social media platforms at Redefine Health Ed. The only one that I couldn't get to be at Redefine Health Ed was Twitter because it was 1 character too long. So Twitter, we are at Redefine Con Ed, just to make sure that we're different on one platform. I definitely want to say thank you so much to our partners, awesome strategic partners, just great people, great businesses all around. The PT Pintcast, the OncoPT, PhysioSage, Modern Manual Therapy, Survivorship Solutions, and DUZA, which was just started by a colleague of mine, Dr. Julie Skurzat, and it's all on cardiovascular and pulmonary physical therapy. She's a star. Check her out on Instagram at DUZA, DUSZA LLC. And she had a post in there about what that name is all about. So please enjoy this very first episode and keep listening because it's just going to get better and better from here. Here we go. Sup, Rachel?
Hey. What up?
What up? So for those of you listening, there's probably literally nobody listening, but for anybody who might end up listening to this, Rachel and I met originally we met at that APTA, the Credential Clinical Instructor course.
Yeah, you were so pregnant.
I was so pregnant. Oh my gosh. I forgot about that just until right now.
Yeah.
So I was really pregnant, and me and Rachel met there. I was still in the Army, and then lo and behold, like I had my baby, got out of the Army,
not because I had the baby, but just because it was time. And I ended up getting a job at the University of Oklahoma's Cancer Center, and Rachel worked there. And I was like, you look really familiar. Like, and then
I'll never forget you because, like, you were the one who just, like, you had a question for everything. You were like, wait, but.
Did you know that
Yes.
my DPT class at Temple, when I graduated, we actually created a yearbook. Somebody in our class,
Mm-hmm.
Arthur No, one of my classmates. Arthur, if you're listening, shout out to you because you're awesome. I think he and like some other people got together and created this yearbook, and I was the girl who was most likely to ask a question. It's like, surprise.
You live up to your reputation very well.
I guess so.
They're really good questions, though. At least they weren't like,
Yeah.
a bad question.
Yeah, I'm sure I've asked too many annoying questions at some point. So, yeah, so then we started working together at the Cancer Center, and I don't know, our relationship sort of took off from there, and we would go for walks and talk about endless possibilities and opportunities for business and for our cancer patients and for, like, I don't know, we just talked about everything. So, Rachel, tell me about you and tell me, like, well, I know a lot about you, but tell the people that may or may not be listening to this.
Audience of two.
Yeah,
this is my mom.
give us your elevator pitch.
Oh man. Okay, so my name is Rachel Neuhold, and I graduated from PT school from the University of Oklahoma. And my very first job out of school was actually at the cancer center. It's actually
How did you get that job?
I was gonna say it's a story of procrastination and not wanting to grow up.
So typical.
I was just like, I was tired of school, and so I was like, I'm not getting a job right after I graduate. Like, I like took a summer off. I went to like England. I was like, screw working. And then
you didn't know that?
Yeah,
I had no idea.
I went to England. It was really fun, like on a work trip. Like, I randomly got a like job with my friends, and they decided to take me to a free trip to England. So.
Oh my gosh, you're kidding! I never knew that.
I worked there like a month and a half, and they took me to England. So I was like, okay.
Whoa.
And so I swore I was going to leave the Oklahoma. I just like knew it was time to move to the ocean, and I didn't. And so since I didn't look for a job right after school, all of the jobs were filled up, and so I couldn't find a job anywhere until I asked one of my old clinical instructors. I was like, just like begging. I was like, do you know of a job? Because like I ran out of money and I didn't have anywhere to like live or anything. So she like randomly was like, yeah, we're looking over here at a cancer center. And so I don't have a great story of like always like I had longed to work there. It was just like life played out the way it should, and like somehow I ended up there and they hired me. So that's how I got there.
Awesome.
And now I've been there the whole time.
Right. So like 5 years at this point?
Yep.
Wow.
About 5 years, yeah.
Oh my goodness. So interesting. So that's crazy. I never, out of like all the time that we've known each other, I never knew that you went and worked in London or wherever you were. So you basically didn't know much about cancer prior to even starting there. Like what was that like? What was the learning curve, and what were your expectations? And
yeah, well, the learning curve was fairly steep, but when I first started, the clinic was fairly new in general, and so our patient load was like so low. Like I remember when I started, I had like 3 patients a day, but what I thought was so interesting was like the lack of knowledge by other providers about like what PT could do in a cancer setting. So like we would get only a few referrals, and it was like the easiest job because I saw 3 patients a day. But we literally just, nobody would refer to us. And what was crazy is we were like in a cancer center. So
Yeah, so just so that like I obviously know because I worked there, but just explain what your setting is. So, outpatient versus inpatient, just so that everybody is clear.
right.
Because I didn't know before I got the job there. I didn't even know what it was. So explain
Yeah.
that.
So we're technically outpatient. And our clinic is technically inside a cancer center. So all they do see is cancer patients, and then like through their journey and post, and like to survivorship care. So we're like outpatients. So we see patients from like the day they're diagnosed, some of them, to while they're in treatment, to all the way like years after. So we see the full range of treatment spectrum. But yeah, we're technically an outpatient center in the cancer center.
Gotcha. So you started off, you had like 3 or so patients a day. And what were your expectations? Like, how were your expectations changed of when you got this job at the cancer center? What were you expecting? And then how did that change over time?
So I probably, like everybody, was expecting like really deconditioned patients, like people who just who was like really thin, really small because they lost all this weight from cancer. So I kind of expected it to look something like that. And it was like almost the opposite of what I saw. It was actually kind of crazy. I never realized the range of deficits that cancer treatments and cancer itself can cause to a person and their quality of life and their physical well-being. So I had no idea what I was getting into when I went into that fateful interview that day. And I will have to say, like, it is one of the most rewarding and fascinating PT settings that I think that there is. It's just crazy what I've learned in 5 years that I never thought I would. So,
what do you think is the most fascinating about it, or what interests you the most? I mean, there's probably a lot of things, but try to pick, top couple.
So I'm always asking questions. Like
we have that in common.
Yeah. I've heard this before. I'm like very curious, and I tend to get bored really easily. And what I love about this setting is that I never know what I'm walking into, because there's new cancer treatments coming out every day, which have new side effects, which can affect patients in all kinds of different ways. And so I think that learning about these life-saving treatments, but also life-altering treatments, and how each person can have the same treatment but have different side effects and different reactions is just crazy to me, and how their past medical history can so much determine what their side effects can be, and their age, and just like all of these factors that you have to play in your head to try and figure out and put these puzzle pieces together on like, what are you seeing in a patient? So I think that's cool, because I'm always like interested. Like, I'm like, wow, this brand new chemo, like, we're part of phase 1 clinical trials. And so sometimes they'll have us look and monitor for what are the side effects of these brand new drugs. And so we can report back to the physicians like, hey, like we had a phase 1 trial where every single person was getting the most crazy neuropathy and almost like ataxia, where the chemo was attacking almost their central nervous system. And actually, based on like what we would tell the physicians, they actually stopped the trial drug, at least at our center. So I think that collaboration is pretty cool. And so that, and I kind of forgot the question, but one of the things I like the most probably about where I work is the people that I work with, my patients. I guess a misconception when I first started was that And what I tell people I work there, they're like, man, that's like got to be so sad. And what's crazy is it's the complete opposite. It's like so full of hope. And the hardest working patients I've ever been a part of, like, nobody going through cancer is going to do PT if, like, they all want to be there. None of them are going to come if they don't want to. So I have people who life has been taken away from them and they're fighting to get it back. So my patients are so inspiring to me, and I love that part the most, I think.
Mm-hmm. So I have to echo everything that you just said about when I first started there. One of the things that inspired me to even apply for this job, because, you know, it's the C word. Like, everybody's afraid of cancer. But if you don't know anything about it and you've never, you know, everybody knows somebody who's had cancer, and it's just like this big scary thing. And the one thing that inspired me to even apply for that job was I had a service member. I think I told you about this. I had a service member when I was in the Army. He came in with hip pain. He was 37, very, very fit. He was a National Guard soldier in his civilian job. He was a SWAT team member. So, like, you know, big Hulk looking guy. And he came in with hip pain, and the only thing that reproduced his hip pain was like a single leg hop or running, just some kind of impact activity. And nothing else in his physical exam was provoking his symptoms at all. It was in a very unusual location. So turns out, like, we ended up doing a workup very quickly, and his hip pain was originating from an osteolytic lesion in his right ilium. And very, very sad case that he ended up passing in like 6 weeks. And he had no symptoms, nothing else, you know, none of the typical things that you would think of or that we were taught in school, like, do you have pain at night? Have you lost a ton of weight? Mm-hmm. All of these factors that we learn about, a lot of the cancer patients, I guess fast forward, a lot of the cancer, the individuals with cancer that we worked with, it's like they come in and they don't necessarily have those types of symptoms. Right. that you learn about typically. So that's the one that was the one case. It touched me to be a part of the early identification, I guess, and workup process, and I developed a relationship with that soldier because I knew the system. It wasn't great at Fort Sill, and he was a trainee, so it, like, you know, he just didn't have, I knew that he wasn't going to have good communication. So I ended up giving this guy my cell phone number. I was like, text me, like, anything that you need, because I knew it was bad. And so that case has stuck with me since then. And when I applied for this job, I was really expecting to see a lot more like devastating cases like that. And it was the total opposite. My experience at the cancer center was like, probably the best experience that I have ever had in not only working with cases and, like, being able to determine differential diagnosis, like, is this pain that this person's having actually coming from their cancer, or is it coming from their hip joint, or but the patients, good Lord. I mean, I hardly remember any patients' names from when I was in the Army. I hardly remember any of them. I remember almost everybody that I worked with at the cancer center, because I loved it so much, and I was not expecting that as an orthopedic specialist going into it. So it is a place just full of hope, and I totally echo that statement, and I would encourage anybody that is in a regular outpatient clinic to learn more about it and to be more accepting of it, especially like the prehab component. So I want you to talk a lot about some of the prehab programs and, like, the effect that has had, or the effect that has made in the patients that you've worked with.
Yeah, so that's one of the big things that we're trying to promote. Kind of, I think the thing that probably most therapists can relate that to is, like, prehab prior to, like, total knees. You know, like, it has shown improved outcomes with orthopedic surgeries to do prehab. So what we're trying to establish in the oncology field is the same type of thing. Like, if you're going into these big surgeries where, like, if you have pancreatic cancer, they're taking out your pancreas, which is a huge surgery full with like comorbidities and complications, and you get diabetes afterwards. Like, how can we increase your strength and physical condition prior to your surgery, so hopefully your comorbidities are less, you get out of the hospital sooner? And then in cancers like GI related cancers like colorectal cancer and pancreatic cancer, there's actually pretty good evidence that shows that people who are more fit, who have a higher muscle to fat ratio, actually live longer. I was looking at some evidence that shows they did cross-sectional analysis of with CT scans, and they did it with people, I think both colorectal and pancreas, and they found, I think, that patients lived on average like a year longer if they had a higher muscle content. That was the only thing they looked at, was higher muscle content. So that just like goes to show, if you're in better physical condition before your surgeries or before you even have cancer, your outcomes are better. And there's a lot of literature in like prostate and breast cancer that if you are active or physically, like if you exercise, you, one, decrease your risk of getting those cancers, but two, you reduce your risk of reoccurrence of those cancers purely through exercise. So I think PT has a big role to play, and even just in those components, like preventing cancer or helping you before your surgeries, all of those types of things. So there's the like prehab to get you stronger, but there's also like, I think, a really important role in physical therapy and education with these types of patients. Like for breast cancer, what comes to mind is like they need to know about lymphedema before they even go into some of these surgeries. And so they know what to look for, and they're aware of signs and symptoms that they may have, where they can just come to us. They don't have to wait for a physician referral. They're like, Rachel, I know you talked about swelling in my arm and I have it now. Will you help me? And we can decrease costs of management of lymphedema that gets really bad. We can help prevent people going to the hospital if they get an infection, because they know what to do about it. So there's lots of different roles in education as in prehab that I think are important for physical therapists to own in their practice.
Absolutely. And I think, so two things on your comments. The first one is the mention of muscle mass. That like sole factor has been studied, and it's being studied across the board in so many different conditions. I went to a lecture at CSM this year about, were you in that one, about sarcopenia? I think I told you about it. It was like the very first day at 8 a.m.
Yes, I wanted to go.
Oh my God.
Yeah.
It was so good. And I don't even remember the context, but I remember that theme was echoed through a lot of other talks. So like sarcopenia and just the idea of decreased muscle mass leads to or contributes to, is correlated with so many other conditions, osteoporosis, and like, what do we do for osteoporosis? Weight bearing exercises and resistance training to help build up that bone density. There's so much that is taking, when people think of PT, I think they think about they think about strengthening and stretching, and
yes.
Like
yes,
yes, but no. Okay, like there's so much that happens metabolically, like at the cellular level, with exercise, that you're changing not only in the muscle fibers, the little myofibrils, but you're changing the nervous system, you're changing the heart, like you're literally changing insulin sensitivity.
I know. You're changing your immune system, which is cancer fighting. Your cancer fighting immune system, you're making better through exercise.
I know, and it's something that is so simple that has such a strong effect. Like, we know that exercise is one of the only proven things to help with cancer-related fatigue. And I remember educating patients on that at the cancer center, and they were like, huh? Like, if I'm tired, I don't want to work out.
Right. No, that's like the best evidence. The best
Yeah,
evidence is exercise. So
I know. And so muscle mass, huge, huge thing. And then the second thing you were talking about was, man, now I forgot. Was it like, were you talking about like, oh, like education? So
yeah.
educating the patient. So right off the bat, when patients are diagnosed with cancer, it is effing scary. I mean, like, how is that not probably like one of the worst moments or the worst moment of anybody's life? It is scary. It is full of fear. It's full of questions. And at any given point, the patient is probably like Googling and talking to people and all of this stuff. And we at the Stephenson Cancer Center, we had 90-minute evaluations where we would sit and spend all of this time doing multiple batteries of not only subjective measures, but also like physical. Depending on the type of cancer, we would also do a specific battery of physical assessments. And then have all of this time to be able to educate the patient and help to reduce their fear. And I think that of the patients that ended up coming to see us for like that initial prehab session, kind of right around the point of diagnosis, even before they start treatment, that was all of the, I just remember all of those patients being so grateful. And like they leave just with more hope that they can do something. It puts that it gives them more control over the situation.
Yes.
And I loved that. I loved that I was able to be a part of that. I wish I was still there a little bit.
I was gonna say, like, you were an awesome addition to our team for so many reasons. But one of the things that I wanted, no, it is. It's so cool. And I wanted to like throw a question to you because you came in and added a great orthopedic presence to our clinic that we didn't have. And like, so I would actually, like, you went in and like actually worked with orthopedic oncologists and went to their clinics and saw like these crazy cases. You saw these crazy surgeries that you would otherwise not see. So I was going to throw it back to you and like, from your perspective as an orthopedic therapist, where do you think that like orthopedics and cancer, how do you feel like that goes together?
Okay, so I'll give you my perspective from before being at the cancer center to after being at the cancer center, and especially being at the Stephenson Cancer Center, because I think that if I would have gone to other places and been around other people that maybe aren't as like forward thinking and progressive as you and Vicki Davidson and Dr. Heil, like I don't think I would have been able to fully appreciate it. But so coming in, I was thinking like, oh my gosh, like I can't even do joint mobilizations on these people because their bones are gonna break. And exactly, like what can we do? Are we gonna tear their muscles if we give them a 1 pound weight? Like I especially coming from the Army setting where I'm working with a bunch of able-bodied people for the most part, I was nervous. I really didn't know what I was doing, and I leaned on you guys so heavily. But what I learned over time was like, you can really do a lot, and you're doing individuals a disservice by not pushing them and by carrying on. This is another topic we'll get to, which I'm really excited about. But by following like old school recommendations and contraindications and things that are really not evidence-based, you're probably doing the patient a disservice. And I'm so glad that I learned from you guys in that way. But as far as like learning about orthopedics, it upped the ante for me, because when you work with an individual that has bony mets, you kind of have to, you sort of have to make a decision, because if they have multiple myeloma and they have bony mets all over, are you just going to tell them to like lay in bed Like that's what I was like, oh my gosh, this guy has a lesion in his clavicle, in his ribs, all over his spine, in the pelvis, in the acetabulum. Like, what am I supposed to do with this patient? But he literally has no pain. So that's when, like, I hope that, like, I'll tell Dr. White about this. Hello, Dr. White. Dr. Jeremy White is the orthopedic oncologist. Is he still there? I'm assuming.
Yes.
So Dr. Jeremy White is the orthopedic oncologist at the Stephenson Cancer Center, and he came and gave us like, I think we all talked about it, and we're just like, maybe, like, we really need to get some answers from him and collaborate. And he came and did an awesome roundtable discussion with us, taught us a lot about bony mets and the treatments that you can do for it, and that it's not really been studied very well. Like, what are the thresholds? What can you do? So the bottom line was, like, we really used pain and function as a guide. And then always, he was like, if you ever have a question, if you ever, like, see something and you just have a question, just send me an email, shoot it over. And I loved that collaborative model. It was exactly the way that I feel like healthcare should be. So for me, it just totally upped the ante. I feel so much more confident in my orthopedic skills because, again, like I said at the beginning, I was just used to, like, looking at a knee, and a knee is a knee. And,
right.
It's like, okay, is it patellofemoral? Is it knee OA? Is it a meniscus issue? Like, what's the deal? On this end of the spectrum, okay, is the knee pain, is it kind of like, is it a little bit of OA plus a little bit of, like, the chemotherapy is increasing your central sensitivity, and it's going to fluctuate, and it's going to come and go based on your chemo cycles, because we saw that all the time too. So I don't know. For me, it just really upped the ante. It made me ask so many more questions than I already had, in a good way. And
yes.
I am forever grateful for the experience. And I mean, I will take. I've actually been hoping for more oncology patients to get into my practice. It's just I can't find them.
I
know, right? I know. So yeah, do you have any, like, does that answer your question? I don't know.
Yeah, no, it does. It really does. Like, I'll never forget one of the craziest, like, orthopedic cases I had. It was, like, my first year out, and I saw a patient with a soft tissue sarcoma, and they took out, like, a third of their quad.
I remember that.
And then they still reattached it, and then they had to do, like, grafts from other places. And I had no idea how to help this dude walk again, because half of his patella's gone, half of his quad's gone, but he still needs to walk. I had no idea, like, when he was at full capacity, because I don't think he could ever get full knee extension based on his, like, bony anatomy. It was very interesting, and it was crazy and very thought-provoking for sure. So yeah, it's like,
well, and I think that these cases, whenever you see them, it's like, there's no guidebook for a lot of this stuff.
Nope.
And you have to be able to make the decision as the professional in biomechanics and movement science and function, really. You kind of have to be the person to say, what is going to be the end state? Are you going to be able to return to full function, or how can we adapt? And it's just such a great way to learn.
Yes. I was gonna say, like, I think it's great for, like, the oncology field is great for anybody who, like, likes to ask questions and, like, not have a guidebook. Like, if you want a guidebook, probably don't go into oncology, because there's no. But if you want to help create a guidebook, then, like, come on. Like, I think it's a great field for research and learning and opportunity. So
just exploration, like, pioneering. I think if you want to be a pioneer, and you're not afraid to try new things or different things or think outside the box, the oncology setting is pretty darn phenomenal for that. I have to say.
Cool. It's pretty cool.
That's it for this episode. Stay tuned for part 2. If you haven't already, visit our website at www.redefinehealthed.com. Check out our upcoming live courses. They're available through 2021. Give us a follow on all the social media platforms at Redefine Health Ed, except for Twitter at Redefine Con Ed.